Hello friends, so today we are going to discuss about the concept of the royal orthopedic nerve, that is the radial nerve. Every orthopedic surgeon has always been apprehensive and afraid of this radial nerve throughout his life, be it a wrist drop case in his or her practical examination or a case of radial nerve palsy pre-operatively or post-operatively in his clinical practice. So today what we are going to do is we are going to understand in detail the concept of radial nerve palsy, that is wrist drop. So without further ado, let us begin with our concept of wrist drop. Okay, so what our plan for today is? We are going to understand the radial nerve course and anatomy in detail. We are going to understand the functions of the muscle supplied by the radial nerve. We are going to understand the possible sites of injury vis-a-vis the functional loss. We are going to understand a key. We are going to remember a key to delineate the site of injury in cases of radial nerve palsy or PIN palsy. We are going to understand the common etiology of wrist drop, finger drop, or thumb drop. And at the end, what we are going to do and understand is for the clinical practice, we are going to understand the management protocol, and we are going to understand in detail the concept of tendon transfers. Okay, so without further ado, let us begin the concept of radial nerve course. Okay, so this forms the crux of understanding the concept of wrist drop and radial nerve palsy, because this is the basic anatomy which will give us the key to delineate the site of injury. Okay, so how does the radial nerve form? It is the terminal branch of the posterior cord of brachial plexus, that is C5 to C8 and T1. Going distally to in the axilla, it runs behind the third part of the axillary artery and then runs behind the brachial artery. Okay, so this is the course in axilla. Now when it enters the arm in the posterior compartment. Okay, so it enters into the spiral groove. So we'll understand the anatomy before entering the spiral groove and after entering the spiral groove. Okay, so this is the course in the posterior compartment of the arm. Going distally, it pierces the lateral intermuscular septum and it reaches the anterior compartment of arm. Okay, it reaches the anterior compartment of arm. So this is the schematic figure. So the radial nerve, it begins in the axilla, it enters the spiral groove, then pierces the lateral intermuscular septum and enters the anterolateral compartment of the arm. Going distally, it divides at the lateral epicondyle. Into superficial radial nerve and posterior interosseous nerve. The superficial radial nerve is pure sensory branch and posterior interosseous nerve is the pure motor branch. Okay, so we'll understand the concept based on axilla. First part is axilla. Second part is before entering the spiral groove. Second part is entering the spiral groove. Third part is piercing the lateral intermuscular septum and entering the anterior or anterolateral compartment, and then at the elbow where it divides into PIN and superficial radial nerve. Okay, so this is the concept, this is the basic crux. You need to understand this. Axilla, then it goes distal into the posterior compartment, enters the spiral groove, then it pierces the lateral intermuscular septum and reaches the anterior compartment of the arm. Then it reaches the lateral epicondyle and divides into posterior interosseous nerve and superficial radial nerve. Posterior interosseous nerve is the deep motor branch which enters the forearm via radial tunnel under the supinator. Am I making sense? So PIN enters the forearm under the radial tunnel under the supinator. However, superficial radial nerve is a pure sensory branch which descends under the brachioradialis. So in the approach to forearm, you always check for these two nerves, these two branches. Under brachioradialis, you find the superficial radial nerve, and under supinator, you find the posterior interosseous nerve. Am I making sense? Clear? So axilla before entering the spiral groove, after entering the spiral groove, this was the posterior compartment, enters into anterior compartment by piercing the lateral intermuscular septum, goes to the elbow, divides at the lateral epicondyle into superficial radial nerve and posterior interosseous nerve. Am I making sense? Okay, so this was the basic. Now what you are going to discuss is the muscle supplied at which location. This is important. This is important. Okay, so in the arm, after going distal from the axilla, when the nerve is at the posterior compartment, before entering the spiral groove, it supplies the long head of triceps. Okay, before entering the spiral groove, it supplies the long head of triceps, and after entering the spiral groove, it supplies the medial and lateral head of triceps and enconeus. Okay, so to make this concept clear, we are going to remember with a mnemonic. So in the posterior compartment, it supplies the long head of triceps before entering the spiral groove, and medial and lateral head of triceps after entering spiral groove, and enconeus. So in the posterior compartment, it is T and A. Okay. Then going distally, it pierces the lateral intermuscular septum and enters the anterolateral or anterior compartment, where it supplies the brachioradialis and ECRL. Okay, it supplies the brachioradialis and ECRL. So in the anterior compartment, it supplies B and R, brachioradialis and ECRL. Am I making sense? So it is TABR. Okay. Now going distally, right now we are going discussing about the muscular supply. So distally, SRN, superficial radial nerve, is pure sensory. So we are going to discuss about PIN only. So in the forearm, it divides at the lateral epicondyle. Then PIN passes via the radial tunnel under the supinator. Okay, under the supinator, and it supplies the supinator muscle. It supplies the wrist extensor, that is ECRB, ECU. It supplies the thumb muscles, EPL, APL and EPB, and it supplies the finger extensor, that is extensor digitorum communis, extensor digiti minimi and extensor indicis. Am I making sense? So in the forearm, it supplies SE, that is supinator, and all the extensors. Which all extensors? So you need to make this clear. In the anterior compartment, it supplies the ECRL. However, going distally, it supplies the ECRB and ECU. Am I making sense? ECRL in the anterior compartment, in the arm. However, ECRB in the forearm. Okay, so in the forearm, it supplies the supinator and the extensors. Which all extensor? Wrist extensor, ECRB and extensor carpi ulnaris. Okay, the thumb muscles, EPL, APL and EPB, and the finger extensors at MCP and interphalangeal joints. Okay, so our keyword is TABRSE. Am I making sense? We are going to discuss it again. Okay, so what are the functions of the muscles? This is the most important slide. So before entering the spiral groove, it supplies the long head of triceps. And after entering the spiral groove, it supplies the medial and lateral head of triceps and enconeus. What is the function of triceps? It is elbow extension. Okay, it is elbow extension. What is the muscle? What is the function of enconeus? It is also elbow extension. Okay, am I making sense? So in the posterior compartment of arm, it supplies the triceps and enconeus, whose basic function is elbow extension. Okay, going distally, it pierces the lateral intermuscular septum. And goes in the anterior or anterolateral compartment of the arm, where it supplies BR, brachioradialis, and ECRL. What is the function of brachioradialis? The main function is forearm supination. It was also weak elbow flexor, but main function is forearm supination. The second is ECRL. So ECRL causes wrist extension and radial deviation of the wrist. So ECRL is a wrist extensor. Along with that, ECRB is there, but ECRB supplies distally. ECRL supply is in the anterior compartment of the arm. Okay, after piercing the lateral intermuscular septum, it supplies brachioradialis and ECRL. So this is the function: forearm supination, wrist extension, radial deviation of the wrist. Keep this in mind. This is the key. These are the clue which we are going to discuss in the further slides. Okay. Now, forearm, as soon as it enters the forearm via the radial tunnel, we are talking about PIN. So, PIN supplies SE. What does it supply? SE, that is supinator, which causes, so what is the function of supinator? It causes supination, as simple as that. What are the extensors which are supplied by PIN? So, at the wrist, it is ECRB. What is the function of ECRB? It exactly supplements ECRL, that is wrist extension and the radial deviation of the wrist. It supplies extensor carpi ulnaris. What is the function of extensor carpi ulnaris? It is wrist extension and ulnar deviation. Mark my words, keep this in mind. Radial deviation by ECRL and ulnar deviation by ECU. Okay. Then it supplies the muscles of the thumb, that is EPL, APL and EPB. Okay. Now it supplies the finger extensors. What are the finger extensors? Extensor digiti communis, extensor digitorum communis, which causes the finger extension at MCP in all four fingers. Extensor indicis, it causes finger extension at MCP, DIP and PIP joint. MCP, DIP and PIP joint at the index finger. And extensor digiti minimi causes little finger extension at MCP, PIP and DIP. Am I making sense? So this was the function you need to understand. I am repeating again and again because this is the part that needs to be lipid soluble to you. Then and only then you can understand the radial nerve, palsy and wrist drop concept. Okay. Posterior compartment, it supplies TA, triceps and enconeus. Function is elbow extension. In the anterolateral compartment, going distally, it supplies BR, that is brachioradialis and ECRL. Brachioradialis function is forearm supination and ECRL function is wrist extension and the radial deviation of the wrist. Going distally, it supplies in the forearm. PIN supplies SE, that is supinator causing supination, and E, that is wrist extensor ECRB, extensor carpi ulnaris, finger extensors and thumb extensors. Am I making sense? Okay, so this is the very important slide. So the muscles supplied are first TA, BR, brachioradialis, so triceps, enconeus, brachioradialis, ECRL, supinator and extensors. Okay, so this is the posterior compartment of arm, this is the anterior compartment of arm, and this is the forearm. Okay, so this was the basic crux. Now what we are going to understand, the sites of injury and the function based on it. Making sense? We are going to understand the sites of injury and the loss of function based on it. Okay, so whenever there is high radial nerve palsy at the axilla, okay, before entering the spiral groove, so whenever it is high radial nerve palsy at the axilla, obviously all the supply is gone. Okay, so triceps and enconeus supply is gone, so elbow extension is gone. First we are going to discuss about the motor component only. In the further on slide we are going to discuss about the sensory supply as well. Okay, but not to confuse, let us discuss about the motor first. Okay, so triceps and enconeus is gone, so what is gone? Elbow extension is gone. BR is gone, so brachioradialis and ECRL is gone. Brachioradialis is gone, so supination is gone. ECRL is gone, so wrist extension and radial deviation is gone. Right? Going distally, SE, so supinator is gone, so supination is gone. So both brachioradialis and supinator, both are the supinators, both are gone, supination is gone. Then going distally, E, so extensors are gone, the thumb movement is gone, thumb muscles are gone, so it causes thumb drop. Finger muscles are gone, so it causes finger drop. And at the wrist extensors, ECRB is gone, so wrist extension is gone. Extensor carpi ulnaris is gone, so wrist extension and ulnar deviation is gone. Okay, so all the muscles supplied by radial nerve are gone in the case of high radial nerve palsy at axilla. So what is gone? Elbow extension is gone, supination is gone, wrist extension, radial deviation is gone. Wrist extension, ulnar deviation is gone, thumb movements and finger movements is gone. So there is a classical picture of gone elbow extension plus wrist, thumb and finger drop. Am I making sense? Okay, so this was the lesion at high above at the axilla. Now going distally, radial nerve palsy after entering the spiral groove. So what is preserved? What was the supply before entering the spiral groove? It was supplying the long head of triceps, So after entering the spiral groove, long head of triceps supply is preserved. So which function will be preserved? The elbow extension will be preserved. So definitely there might be some weakness because medial and lateral head of triceps are gone. But as it is after entering the spiral groove, long head of triceps supply is preserved. So elbow extension is preserved. Rest is same. What is same? Wrist drop is same. Finger drop is same. Thumb drop is same. Okay. Now what happens is if radial nerve palsy is distal to the spiral groove, so what happens is triceps all three heads are preserved, at the same time enconeus is preserved. Am I making sense? Are you getting the catch? So triceps all three heads, okay, because the radial nerve palsy is distal to the spiral groove, at the same time enconeus is preserved, so elbow extension is spared completely. There is no absolute weakness in elbow extension. Rest all, that is supination is gone, wrist drop, finger drop, thumb drop, all these are same, but elbow extension would be 5 by 5. Okay. Now going distally, if the radial nerve palsy is at the lateral intermuscular septum, what is preserved? TA is spared, so elbow extension is spared, similar to what it is distal to the spiral groove. But brachioradialis, it is just the lateral intermuscular septum, so it has not yet supplied the brachioradialis. So similar, brachioradialis is gone, so supination is gone, ECRL is gone, so wrist extension, radial deviation is gone, supinator gone, SE, supination is gone, and wrist, thumb and finger extensors all are gone. So the similar picture what you see. Okay, so this was the picture if the palsy occurs at the lateral intermuscular septum before supplying the brachioradialis and ECRL. Okay, now what happens is if the radial nerve palsy occurs at the elbow distally after supply to the brachioradialis and ECRL, in the anterior compartment of the arm, so what is spared? Obviously in the posterior compartment, what was supplied? It was supplying triceps and enconeus, so elbow extension is preserved. At the same time, brachioradialis and ECRL is spared. So if brachioradial is spared, what is preserved? Supination is preserved. If ECRL is spared, what is preserved? Wrist extension is preserved. There might be weakness because ECRB and ECU are lost because their supply is distal, but still ECRL is working, so wrist extension is spared. But what is lost? The supinator is lost, but the supination is done by brachioradialis. So there might be some weak supination, but supination function is preserved, but supinator muscle is gone. And ECRB and extensor carpi ulnaris is gone. So weak extension and ulnar deviation is absent. But radial deviation is present because ECRL is spared. So what will happen? There will be radially deviated wrist. We'll discuss again. What else is lost is finger drop and thumb drop because the finger muscles and thumb muscles are gone. Okay, so am I making sense? If the radial nerve palsy is at the elbow distally after supplying the brachioradialis and ECRL, okay, so elbow extension is spared because triceps and enconeus is normal, brachioradial is spared, so supination function is normal, ECRL is spared, so wrist extension function is normal. So what is lost? There is finger drop and thumb drop. Along with that, ulnar deviation at the wrist is lost. Okay, so you'll understand. So ECRL is intact, so wrist extension is possible, radial deviation is possible, but extensor carpi ulnaris is gone because its supply is distally in the forearm, so ulnar deviation is lost. So if there is a presence of wrist extension with radially deviated wrist, it is a classical picture of PIN palsy. Okay, so PIN plus SRN, superficial radial nerve, or just PIN palsy. We are at present discussing about the motor component only. Okay, so this is the classical picture. Of how PIN plus SRN or PIN palsy presence to you. We are going to differentiate that in the further slides. Okay. Now at the elbow distally, we want to know whether the lesion is. So what happens is at the elbow, at the lateral epicondyle, it divides into posterior interosseous nerve and superficial radial nerve. Divides into posterior interosseous nerve and superficial radial nerve. Okay, so before division, if the radial nerve palsy, if the lesion is before division, then superficial radial nerve and PIN both are gone. However, if the lesion is distal, if the lesion is after the division into superficial radial nerve and PIN posterior interosseous nerve, then if the SRN is gone, we find the sensory loss. If the PIN is gone, we find the motor loss. So to understand whether it is a SRN plus PIN palsy, or it is pure SRN palsy, or it is pure PIN palsy, we need to understand the sensory supply. Now the motor component should be clear. That is the most confusing part. But once you understand, it becomes an absolute cakewalk. Okay, now sensory supply is pretty much simple. Autonomous zone of the radial nerve is first dorsal web space. This you need to keep in mind. Okay. Now, what does it supply? Which locations it supplies what? So at axilla, it gives the posterior cutaneous nerve of arm, which supplies the posterior arm, which is the proximal 2/3 part. It supplies the posterior aspect of the proximal 2/3 of the arm. It gives off posterior cutaneous nerve of arm. Now at the spiral groove, it gives off the posterior cutaneous nerve of the forearm. It gives off the posterior cutaneous nerve of forearm, which supplies the posterior aspect, a band in the forearm. Okay. Now at the lateral intermuscular septum, it gives off lower lateral cutaneous nerve of arm, which supplies the distal 1/3 of the lateral arm. The classical thing is lateral epicondyle hypoesthesia. This is how patient presents to you. Okay. Now, after the bifurcation, that is what you need to understand. After the bifurcation, superficial radial nerve runs under brachioradialis and posterior interosseous nerve runs under the supinator. Okay, so what is the supply of superficial radial nerve? It supplies the dorsum lateral half of the hand. It supplies the dorsal lateral half of the hand. It supplies the dorsum of thumb. It supplies the dorsal index plus middle finger up to DIP. The fingertips are supplied by median nerve. Okay, so it supplies the dorsal index and middle finger up to DIP joint. Okay, and it supplies the radial half of the dorsal ring finger. Okay, so this is the supply by superficial radial nerve. I repeat, dorsum lateral half of the hand, dorsum thumb, index and middle finger, dorsum up to DIP, and radial half of the dorsal ring finger. Okay, so this is the sensory supply. Will make us understand and will give us the clue to understand the site of injury. Okay. Now we are going to combine the motor and sensory part, and we are going to give ourselves a logical concept booster key so that we can understand at final. Okay, so if there is a lesion at axilla, what is gone? Everything is gone. TA is gone, BR is gone, SE is gone. Okay, motor supply is gone, and sensory part is completely gone. So elbow extension is lost, supination is lost, wrist extension is lost, wrist radial and ulnar deviation is lost, finger drop, thumb drop, and sensations at the posterior arm, forearm, and the SRN supply, everything is lost. So this is the lesion, high lesion at the axilla. Okay, so just distal to the spiral groove, proximal to the intermuscular septum. What happens is what is preserved? TA is preserved. Okay, so elbow extension is preserved. However, what is gone? Brachioradialis, ECRL is gone. So supination is gone, wrist extension is gone. There is finger drop and thumb drop. However, it is distal to the spiral groove. So at the axilla, the cutaneous nerve of arm, and at the spiral groove, the cutaneous nerve of forearm is preserved. So sensations to arm and forearm are preserved if the lesion is just distal to the spiral groove, proximal to the intermuscular septum. Okay, going on further, At the elbow, if it is, the lesion is proximal to the division into superficial radial nerve and posterior interosseous nerve, what happens is elbow extension is preserved because triceps and anconeus is preserved, supination is preserved because brachioradialis is preserved, wrist extension is preserved because ECRL is preserved. Okay, however, extensor carpi ulnaris is gone. Okay, so ulnar deviation is gone. So what happens is the wrist is radially deviated. Along with that, there is finger and thumb drop, and the lesion is proximal to the division. So the sensory supply of the superficial radial nerve at the hand and finger is also lost. Okay, so this is how you differentiate. Whether it is posterior interosseous nerve palsy, superficial radial nerve palsy, or both. Okay, so whenever the lesion is proximal to the division, so the PI and motor supply is gone. Along with that, the sensation at the hand and finger are also lost. But if you find that the sensations at hand and finger are intact, then you can say that it is a pure motor PI and palsy. Okay, however, if only the sensations at hand and finger are lost, motor component is intact, you can say it is a pure superficial radial nerve palsy. Okay, so this is the basic concept booster. In clinical practice. To understand what is the level of lesion. So if triceps is gone, the lesion you are suspecting at high, for example at the axilla, or a little bit just distal to the axilla. If brachioradialis is gone, you are suspecting a lesion at the spiral groove. If brachioradialis is intact but distal drops are there, then you are suspecting a lesion at the elbow. Okay, so this is the crux. Brachioradialis forms the crux of understanding the level of lesion. You test for the brachioradialis muscle, you know what the level of lesion is. So if brachioradialis is gone, it is a radial nerve palsy. However, if brachioradialis is intact, it is a PIN or PIN plus SRN palsy. Okay, now at the elbow, we discussed this already. I'll quickly discuss it. Before division, if there is a lesion, so superficial radial nerve and PIN both are paralyzed. Okay, so supination is intact with brachioradialis, wrist extension and radial deviation is intact with ECRL because their supply is in the arm. But what is gone? ECRB and ECU is gone, and finger and thumb extensions are gone. So wrist is radially deviated. Okay, because ulnar deviation is lost, but radial deviation is intact with ECRL. Plus additionally, there is sensory loss due to superficial radial nerve paralysis. What is the sensory supply? Dorsal lateral half of the hand, dorsal thumb, dorsal index and middle finger up to DIP, and the radial half of the middle finger. However, if the lesion is after the division, it could be only pure PIN nerve palsy. So there is pure motor paralysis, no sensory loss. Wrist extension is preserved, but wrist is radially because of the ECRL, but it is radially deviated. And what do you see is you see a finger and thumb drop. This is the classical PIN picture. Wrist extension preserved, radially deviated wrist with finger and thumb drop. And if there is only pure SRN nerve palsy, then there is no motor deficit and only sensory supply by superficial radial nerve is gone. So what is the key? Triceps, brachioradialis and sensory supply helps you to clinch to the diagnosis, to the site of injury. Okay, so that was the difficult part. Now what we are going to discuss quickly is the etiology. So at the axilla, what are the common causes? Crutch palsy, Saturday night palsy, axillary lymph node and tumor, shoulder dislocation, more commonly inferior causes such type of paralysis, and iatrogenic axillary lymph node dissection. At the spiral groove, midshaft, most commonly, as you must have seen in the clinical practice, most commonly humerus shaft fracture, Holstein-Lewis fracture, post open reduction internal fixation with plate for humerus fracture. In doing external fixator application, there might be damage due to the pins. And Saturday night palsy with the arm over the chair. These are the most common lesions. You see in case presentation and clinical practice. Okay, and in preoperative case of humerus fracture. Okay, now what are the etiology at lateral intermuscular septum? So whenever there is distal 1/3 humerus fracture, Holstein-Lewis fracture, or whenever you are approaching the lateral or anterolateral humerus approach, paratriceps approach. Okay, Now, what are the common etiology at radial tunnel or proximal forearm? The classical PI and Palsy. So these are classical named findings which are usually asked. So whenever even in the clinical practice you find radial tunnel syndrome very common. So thickened ECRB, eponeurotic edge, which it is named as the arcade of Rose. Okay, and at the recurrent radial vessels, the leash of Henry. These are the named findings of the radial tunnel syndrome, which causes the PIN palsy. What are the common other etiology? Monteggia fracture, radial head fracture, elbow dislocation, radial head, ORIF. Okay. What are the common etiology of superficial radial nerve palsy? Whenever there is entrapment under brachioradialis, we all understood in the anatomy part. How does superficial radial nerve descend? It goes beneath the brachioradialis. So whenever there is entrapment under brachioradialis or brachioradialis ECRL interval, it causes the Wartenberg syndrome, chiralgia parastatica. Whenever there is tight wristband, handcuffs or wristwatch, it causes superficial radial nerve palsy. And while doing fixation of radial styloid with a K-wire, you might encounter a superficial radial nerve palsy. Now we need to understand about the radial tunnel syndrome, which mimics the lateral epicondylitis. So how do you differentiate between the lateral epicondylitis and radial tunnel syndrome? So in radial tunnel syndrome, the tenderness is 5 to 6 cm distal to the lateral epicondyle at the PIN, which suggests a radial tunnel syndrome. What are the tests? The test is resisted supination of the forearm and Maudsley test, which is the resistance against the active middle finger extension. Okay. So this was the basic etiology. Part of the concept of wrist drop. Now we are going to discuss about the most important part for clinical practice. How do you manage a case of wrist drop, be it pre-operative or be it post-operative? Okay. So first we need to understand what are the red flags which requires definitely exploration. First is high energy injury. When you are suspecting a transaction, open injury, compound injuries, penetrating injuries, when you are suspecting a transaction would be there of the radial nerve. Then there is a vascular injury or a compartment syndrome. Then there is penetrating injury. Whenever there is worsening deficit and whenever there is severe neuropathic pain, in all this condition, there is no point of thinking, you directly go for exploration. Now in the management protocol, it is very debatable, but based on the literature, let us understand the basic protocol. Okay, so at the time of injury, if it is a closed injury, usually you go for observation. If it is an open injury like compound injury, you go for exploration. Okay, so this is the basic protocol. Okay, now this was at the time of injury. Now at 6 weeks post the injury, you check for clinical improvement. If there is clinical improvement, what do? You go for observation. If there are signs like Tinel sign, which shows the now regeneration, improving deficits, all these things, you continue observation. If there is no clinical improvement or worsening, you go for EMG NCV. Okay, now at the 12 weeks, if EMG shows improvement as compared to the 6th week EMG and sequential EMGs, if there is improvement, you continue for observation. But if there is no improvement at 12 weeks, you definitely go for exploration. Okay. Now what else? At the 4 to 6 months post injury, if there is either no clinical improvement or no EMG recovery, you definitely go for exploration. Okay. Now, and then at the end, at more than 9 months, you go for tendon transfer. So the ideal time is between 9 to 12 months. We will discuss the reason in the further slides. Okay, so this is the basic protocol of understanding. Now some of the important findings. Basics are: closed fracture, you go for observation for 3 to 4 months. Open fracture, you go for exploration immediately. If there is compression neuropathy like Saturday night palsy, you go for splint and physiotherapy, and you observe for recovery in 2 to 12 weeks. Okay, and if there is no improvement in 3 to 4 months, you go for EMG and exploration. And if there is no recovery at 9 to 12 months, what do? You go for tendon transfer. Okay, why do we go for tendon transfer at 9 months only? We'll discuss in further slides. Okay, now in cases of iatrogenic radial nerve palsy or PI and palsy, what is the protocol that should be followed? Okay, so if the operative procedure was ORIF for humerus shaft, you initially observe for 2 to 3 months. Post ORIF, in post operative period, you see radial nerve palsy or PN palsy, you observe initially for 2 to 3 months. However, if the palsy has occurred during the exposure or nerve handling, if you have handled the radial nerve and postoperatively you find a radial nerve palsy, it is always advisable to go for early exploration and decompression. And however, if the surgery is at the wrist and elbow, it is usually a neuropraxia. So you usually observe for 3 months. So this is the basic protocol. Depends on surgeon to surgeon, but this is the basic protocol that should be followed. Okay, now at the end we have reached the last part of our tutorial. Okay, this we are going to understand the concept of tendon transfer in a case of radial nerve palsy. Okay, so what is the ideal time for doing tendon transfer? It is between 9 to 12 months, more than 9 months. If there is no recovery and no EMG NCV improvement. Okay, why at 9 months? Because muscle and plates lose capacity for re-innervation at 12 months. Muscle and plates lose capacity for re-innervation at 12 months. So 9 to 12 months is the best period. If you delay after 12 months, there might not be good results. Okay, so basically what is the expectation? Which function is lost? So what is lost? Wrist extension is lost, finger extension is lost, and thumb extension and abduction is lost. Okay, so to restore, what are the principles? So what is the principle of tendon transfer? We need to gain back the function. That is lost. So these three functions are lost. Okay, so how to get back the wrist extension? So we can transfer pronator teres to extensor carpi radialis brevis. Okay, we need to do the tendon transfer of pronator teres to ECRB. That is how we regain the wrist extension. Now to regain the finger extension, we use one of the wrist flexor, either FCR or FCU. Either of them we transfer to EDC. We transfer to extensor digitorum communis. Okay, we don't use both, either FCR or FCU to EDC, which restores the extension of all fingers, all 4 fingers. Okay, so this is the concept. Now what to get? We need to get the thumb extension and abduction back. How to get thumb extension back? We use the palmaris longus. If it is not available, we use the FDS of ring finger and we transfer it to EPL. This is how we get the thumb extension back. Okay, so what are the main tendon transfer? Most common tendon transfer at the wrist, pronator teres to ECRB, at the finger, FCR to EDC, and at the thumb, palmaris longus to EPL. Okay, am I making sense? Is this clear? Okay, so my dear friends, that was all about the concept of radial nerve palsy, PN palsy, and the lovely concept, the logical concept of wrist drop, finger drop, and thumb drop. Once you understand the concept, once you understand the crux, the anatomy, and the level of lesion, the nightmare topic becomes a lovely cakewalk to understand and delineate. And that is how we can become more confident in not just in the practical exams, but in clinical practice when we encounter a case of radial nerve palsy pre-op or post-op. This was Dr. Mihir Tejura signing off. Stay tuned for other orthopedic tutorials on my channel, Bones Orthopedics Simplified for You by Dr. Mihir. Thank you so much, guys.